All right. Good evening, everyone. Thank you so much for joining today's ACFAS Virtual Journal Club. As we're getting started here, you'll notice a pop-up on your screen asking how many people are in attendance. So please take a moment to indicate how many people are watching with you tonight. I'm Dr. Michelle Yoakim, and I'll be moderating the session. We're very excited to welcome the San Antonio Sports Medicine Associates Foot and Ankle Surgical Fellowship, led by Program Director Dr. Marque Allen. His fellow is Dr. Suril Amin, and we're also joined by future fellows Dr. AJ Chun and Jacob Riddle, as well as medical student Nitin John. They join us tonight to discuss Hallux valgus surgery, recurrence risk, and minimally invasive versus open correction. I'd also like to take a moment to introduce Dr. Tim Miller from PICA. We are very thankful to him and to PICA for generously supporting this journal club. Dr. Miller completed a bachelor's in psychology at Johns Hopkins University, where he was a four-year letter winner in varsity football and captain his senior year. He graduated from the New York College of Podiatric Medicine in 2015 and was inducted into the Pi Delta Honor Society. He completed his PMSR RRA residency at Atlantic Health Morristown Medical Center in Morristown, New Jersey, where he was chief resident during his third year. He completed his fellowship at the Foot and Ankle Specialists of Ohio in Cleveland, an AACFAS sponsored fellowship. During his fellowship, he specialized in trauma, reconstruction, and advanced limb salvage techniques, such as muscle flaps and peripheral nerve surgery. He became board certified by the American Board of Foot and Ankle Surgery in both foot and reconstructive rear foot and ankle surgery in 2021. He worked at Worcester Orthopedics and Sports Medicine Center in Worcester, Ohio. He then moved down to Orlando, Florida to start his own practice with his wife, who's also a podiatrist. He completed the Chris Mahaffey Leadership Development Program and currently serves on the membership committee for AACFAS. He's involved in AACFAS, ABFAS, ABPMA, and FPMA. Dr. Miller, would you like to say a few words?
Thank you so much for the kind introduction, Dr. Yoakim. I appreciate it. No, I'm really excited to be here tonight. I'm really excited to provide the perspective of PICA and risk management when dealing with hallux valgus correction. And thank you guys so much for having me.
Thank you. All right, so let's get started. Fellows, if you'd like to take it away.
Thank you so much for the kind introduction. Can you guys hear me? Okay.
Yes.
Okay, perfect. Good evening. My name is AJ. I'm an incoming fellow for Dr. Allen's fellowship. Thank you for joining the AACFAS Journal Club. Today's topic is the hallux valgus correction, focusing on the hallux valgus recurrence prevalence, associating radiographic factors, minimum invasive versus open technique. The goal is the critical appraisal. We'll praise the first article, the ASVAR system review and meta-analysis first. Then we'll get to the Quarto randomized control trial. Then we'll briefly synthesize them with the supplemental parameter-based framework. Thank you so much for PICA for sponsoring this journal club. So this slide is basically framed the entire session. The central goal is whether we should first standardize the radiographic criteria, specifically the measurement and angle used to define the hallux valgus deformity before attempting to compare the outcome across the different bunion procedure. The ASVAR paper provide the hallux valgus recurrence prevalent after surgery and associated radiographic factors. The Escuardo paper then compared the MISM versus open technique, and we'll synthesize those two papers and underscore the importance of standardizing radiographic parameter for defining the bunion deformity, which is the prerequisite for making comparison across different surgical procedure. So we'll use the appraisal framework supplied by the AACFAS material. The three main question is the applicability. How can we apply this to our practice? The second is the magnitude precision. Is the result clinically relevant? And the third is validity, which is the paper trustworthy? Those components will make us active reader to evaluate their design and data and whether they provide clinically relevant and meaningful results. So this first article is systemic review and meta-analysis by the Asvar colleague on 2001. The purpose is to estimate the prevalence of the Hallux valgus recurrence after surgery and to identify radiographic factors associated with the recurrence. The author include 23 prospective studies, 2,914 individuals participated, 20 used for meta-analysis, and the strength of this article is the Prisma guided and Prospero register. The next slide is basically that two reviewers independently extract data from the two databases using the predetermined inclusion and exclusion criteria. The total of 23 studies were included for systemic review and 20 were included for meta-analysis. Obviously, this article will formulate the question with the PICO. So PICO is basically the population, someone that had a bunion surgery. Exposure is the pre and post-surgical hallux valgus on the standardized weight-bearing radiograph. What we're comparing is that someone that recurrent and versus non-recurrent hallux valgus. The outcome will be the radiographic recurrence prevalence and associated factors along with it. The key relevant to our journal club is that if recurrence is associated with the postoperative alignment parameters, standardized radiographic measurement and alignment threshold should be used to assess hallux valgus recurrence. So using the systemic review appraisal sheet, the focus question is definitely just clearly stated with the PICO framework with appropriate inclusion and exclusion criteria. The strength of this article is the Prisma structure and Prospero register and quality assessment by the NIH. But the one that concerning point is the heterogeneity. What that mean is that they use a different type of procedure, chevron, scarf, lapidus, you name it. And they also have different recurrence definitions, substantially varies. As some studies said, greater than 20 degree of hallux valgus angle, some say 15. And also the follow-up range from short to almost 10 years. So therefore, the review is useful for identifying broad signal, but not determining the precise recurrence rate for one particular procedure. So let's get into the recurrence rate. Prevalence was 24.86%. The 95 confident interval was 19 to 30, which is pretty narrow, so we can say that it's clinically relevant. I-square heterogeneity was 91.92%, so which indicate very high heterogeneity. So that correct interpretation is that it's not that every bunion has exactly 25% of the recurrence. The correct interpretation is that hallux valgus recurrence is common, and it is premature statement about the association between single bunion procedure and recurrence rate without clear standardization of the adequate correction, including radiographic measurement, angle, and time to assess hallux valgus recurrence after surgery. So this is main analytic results that there's a strong association between the postoperative hallux valgus angle and sesamoid position and recurrence rate. And the defensive takeaway is that the residual postoperative deformity, particularly hallux valgus angle and sesamoid positions, appears to be important. So what makes sense? So what makes sense is that the hallux valgus recurrence is common and it varies across the studies. It is reasonable that residual postoperative hallux valgus angle and persistent sesamoid malpositions are associated with the hallux valgus recurrence. However, the definition of the hallux valgus recurrence was so inconsistent across studies, which contributing the high heterogeneity across the study. So therefore, the study should be interpreted as a signal generating study. And then rather than rather than the single threshold for recurrence. So my practice impact conclusion is moderate. This paper should not make us choose one specific operation. It should change how we read and design studies. If the postoperative Hallux valgus angle and sesamoid positions are strongly associated with recurrence, the future procedure comparison need to report them consistently with those two radiographic measure and angle. The article actually gave us a good information, but the magnitude and precision are limited by the heterogeneity. So let's get into some transitions. So as for our review, tell us which postoperative variable appears to be associated with the recurrence. The next paper will then compare two procedure. But the journal club question become, does the randomized trial measure enough variable to support its conclusion, especially if we believe that recurrence and the residual deformity are multidimensional, meaning that Hallux valgus is not a one-plane deformity, it's a triplane deformity. So next will be Dr. Riddle will take on the second paper. Just let me know when you want to. Next.
Hey everybody, I'm Jacob. I am currently a third-year resident, the chief resident at University of Texas, San Antonio. I will be the following fellow after AJ, Dr. Chun. So I still got another year left, and then I'll be a fellow. But Dr. Allen wanted me to be part of this, but I'll be presenting Article 2. So this next article, it's by Escudero et al. It was published in Foot and Ankle International in 2025. It was a single center study performed in Chile, prospective with parallel group randomized controlled trial, which makes it a level 1 evidence study. Their goal was to investigate MIS versus open treatment of mild to moderate hallux valgus that has failed at least 6 months of conservative management. Their study contained 40 patients with a total of 40 feet, which were randomized. There were 20 patients in the minimally invasive transverse distal metatarsal osteotomy group with percutaneous Aiken, which they abbreviated as MITO. And then 20 patients were in the other arm, which was the open chevron Aiken group. So they followed the patients for 1 year with post-op evaluations at 6 weeks, 3 months, 6 months, and then 1 year. They found that the MITO group had better early wound healing at 6 weeks on the photographic wound assessment tool, the PWAT. Every other endpoint, however, such as patient-reported outcomes, the AACFAS scores, radiographic correction, and complications, were statistically indistinguishable between the groups out 1 year. The trial was powered on the AACFAS score, not on wound healing, and it was not designed as a formal non-inferiority study. And we'll go to the next slide. So for the PICO therapy study appraisal, the population included were patients with mild to moderate symptomatic hallux valgus. The intervention received was the MITO, like we described, the minimally invasive with percutaneous Aiken, and it was compared to the open chevron Aiken osteotomy. The outcomes that they included were wound scores, patient-reported outcomes, AOFAS, radiographic measures, recurrence, and complications. And the clinical rationale was strong, I believe, because it asked whether a less invasive approach was improved early soft tissue recovery while maintaining comparable correction and outcomes. We'll go to the next slide. And the study was designed as a randomized comparison. The randomization was performed using a random sequence generator by an independent investigator. One fellowship-trained surgeon performed all the procedures, which I thought was good. It standardized the techniques, but it also had its weakness, which limited generalizability, as this procedure is very dependent on the skill and training of the surgeon. The population included mild to moderate hallux valgus without other foot deformities. The postoperative management was the same in both groups, including same-day discharge and immediate full weight bearing in a rigid sole shoe. Go to the next slide. And the wound healing results, I thought were the major positive findings. The PWAT, photographic wound assessment tool, score at 6 weeks. It favored the minimally invasive group with a mean of 0.06 compared with 0.42 in the open group, and the P score was 0.02. However, by 3 and 6 months, there was no difference in wound healing between the two groups. The AACFAS score did not differ at any time point. The appraisal point is that the only significance between group findings is an early wound appearance score at 6 weeks. And the authors, they did acknowledge that the study was not powered specifically for wound healing outcomes. So really this observation that they made at best was hypothesis generating, but again, it wasn't powered appropriately, and that wasn't their main endpoint to evaluate. So it's hypothesis generating rather than definitive. But they didn't mention it. We'll go to the next slide. So results. So at 1 year, the groups looked they looked similar across clinical and radiographic measures. The AOFAS and FAAM were high in both groups. The visual analog score pain was low. The IMA correction was similar. The first metatarsal shortening was also similar, and each group had only 3 complications. So this supported the author's conclusion that both procedures can produce improved short-term outcomes. However, again, because of the sample size, it was pretty small, so the study wasn't powered for many secondary outcomes. So absence of statistical significance should not be interpreted as proof of equivalence. Next slide. So complications, again, were equal across both groups, with 3 complications in each group. The minimally invasive group, there was a superficial wound issue from bandaging that they mentioned. There was 1 recurrence and 1 hardware removal from prominent screws. And in the open group, there was 1 recurrence, similar to the previous group, 1 asymptomatic first MTP osteoarthritis case, and 1 transfer metatarsalgia. But again, with only 20 patients per group, I don't think that the study can reliably detect like any uncommon complications or late recurrences, because I think as we know, these deformities, they can recur sometimes much later than just a year out. So I think that the study probably would have benefited from longer follow-up and also a greater patient cohort as well. We'll go to the next slide. So discussion. So we use the intro appraisal. Overall, the foundation of the article I thought was sound and relevant to current trends in our field. It included realistic patient populations with mild to moderate HAV and also evaluated percutaneous MIS procedures, which, as we know, are growing in popularity, being talked about and performed a lot more lately. Coming back into vogue, I guess, now with new industry innovation. So it does add to the literature by re-emphasizing concepts and findings, although I think the limitations of the study were enough that it significantly decreased the overall impact. It compares to the distal procedures without fully delving into and phenotyping the recurrence relevant deformity metrics, such as the sesamoid axial recentering, metatarsal pronation, the DMAA after derotation, the MTP congruency, the metatarsus adductus, which is all things that we're going to discuss a little bit more in depth in the coming slides as well. We'll go to the next one. So the methods appraisal, this was a therapy study. We used the therapy study appraisal sheet. But for the methods appraisal, the groups were randomized, although the authors were not explicitly clear on if the patients were also blinded. That wasn't really mentioned in the article. But I think we can most likely assume that they likely were not, because I think you would be able to tell if it was MIS or not, but they didn't specify. But the groups were similar at the start, mostly, with no statistical significance in the demographics. But as you will see in the next slide, there is still enough variation, I think, between each of the patients with their own unique pathology, which I don't think the authors actually explained as much in their article as they could have. Because as we know, each patient with a bunion is entirely different than others regarding overall biomechanics, soft tissue laxity, etc. But all groups did receive equal treatment and postoperative management with no losses to follow-up. And as we have briefly discussed, the study was not adequately powered for wound healing assessment, which means we cannot reliably conclude that findings are significant or impactful. Go to the next one. So as I just mentioned, this is the table showing the demographics of the different patient populations from both groups, the minimally invasive and the open chevron. Um, So, uh, uh, so each patient, like we know, again, like I mentioned, they each have unique pathology, different varying angles and severity of deformity, which was again minimally addressed by the authors. But as you can see, there is no difference between each group. The similar amount of diabetes per group. The gender was about the same. The patients who were smoking, there were only two smoking patients in the MITO group and four in the Chevron group, which is one thing I thought was possibly interesting too, because they didn't really specify. They mentioned that there was recurrence and delayed wound healing in some of the patients, and I'm wondering if those were due to patients who were smoking or diabetic as opposed to normal healthy patients or patients with average BMI, etc. So I think that's some things that the authors could have explained a little bit better as well. We'll go to the next slide. So the discussion for the results appraisal. Overall, I thought the results, they supported a cautious conclusion in the small trial. The minimally invasive group had better early photographic wound appearance and otherwise similar short-term outcomes compared with open chevron Aiken. The results do not support strong claims of definitive non-inferiority, equivalent safety, or long-term recurrence equivalence. The trial also did not fully address the recurrence parameters highlighted by the first article, as it Tavar, can't pronounce that. But specifically, the postoperative hallux valgus angle and sesamoid position are central in recurrence literature. Yet the trial emphasized that the IM, and the metatarsal length change more than a comprehensive deformity framework. We'll go to the next one. So effect size measures. So using the therapy study appraisal template, this doesn't necessarily apply, I thought, too much to this article. Just because there was only two comparative groups and they both had similar outcomes that were not statistically significant. So naturally, just mathematically, the RR is going to be 1, which just shows the relative risk was unchanged between the groups. The absolute risk reduction also 0%, so no definitive difference. Relative risk reduction as well was 0.15. So basically just showing that there is no difference or increased risk between the groups because of the similar outcomes. Next one. So will this study impact the way that we practice? So the trial has important strengths that I thought I highlighted. I think my main takeaway from it was that the two groups had similar outcomes, which for me as a surgeon, my option would likely be what option am I most comfortable with? And also, what does the patient have? What are their comorbidities? What is the deformity like? Um, and what deformities may the patient have? The feasibility, I believe was dependent on surgeon capability and training. So, um, again, the MIS technique, it does take training and takes time to learn. The study, I thought, did help to re-emphasize kind of what we already know, what we would expect for an MIS procedure, which tend to have less wound healing complications, which I think is why people are using it in the first place. Although they can still occur. But the study was powered using an AACFAS effect size rather than the wound healing endpoint. So it was not designed as a formal non-inferiority trial with a pre-specified margin. So they can't really use that data to come up with anything definitive as a conclusion, mostly an observation. Next one. and we'll move on from here by kind of putting the two articles together and talking about overall how we would essentially rate a bunion, how do we determine if it is corrected, and how do we determine if there is recurrence. So I'll hand it off to Nitin
Yeah, so I'll jump in
or
between, and
Suril first. Yeah.
then we'll take over. No worries. So what do we take away from both these articles? How do we put the information from each together and synthesize it? And I think one of the main things I took away, we should be cautious about technique labels. So, as Tabar in the article that AJ discussed in the beginning, we see nearly a 25% recurrence, which is, if you think about it, that's, recurrence of 1 in 4 bunions. So I think if 1 in 4 of, bunions you operated on had recurrence, you wouldn't be in business very long in your area. But that's what we're seeing in the literature. And it shows that recurrence is associated with postoperative alignment factors, most importantly, your valgus angle and your sesamoid position. And then when we look at Esquardo, they had a small randomized control trial, and they showed the minimally invasive transverse osteotomy procedure with the Aiken may have better wound healing appearance, but their 1 year outcomes were essentially similar to an open chevron and Aiken. So together, they suggest that comparing MIS and open surgery requires standardized deformity components and standardized correction endpoints. Otherwise, the two procedures may appear similar while leaving different residual deformity components unmeasured. Let's go to the next slide. So, kind of we can think about three big take-home points. First, recurrence is common, but the literature is very heterogeneous, as we discussed earlier. Second, postoperative hallux valgus angle and sesamoid position are the most consistent recurrence-associated variables. And in future literature, these are components that really should be looked at and elucidated in the literature. Third, Esquardo trial supports early wound healing advantage for MIS, but does not necessarily prove the superiority of MIS or long-term recurrence equivalence. So we need future research for better deformity phenotyping, standardized reporting, and of course, longer follow-ups. Next slide. So to further connect these two papers, we have somewhat of a measurement issue in hallux valgus research. Estevar showed that recurrence is common, but recurrence rates heavily depend on how recurrence is defined and what measurements are reported. Esquardo compares minimally invasive and open procedure, but the trial still reflects a narrower reporting set than a full set of deformity components. So the framework essentially asks the next question before we decide, is a specific procedure better? What measurements should we require good studies to report so that procedures can be compared fairly? And this leads us to a little preview of a paper we're working on, and Dr. Nithin NJ is going to talk about that a little bit.
Hi, my name is Nithin John. I am a fourth year student from UTRGV. And as Dr. Sorlmin has talked about, we actually don't have anything that's apple to apple comparative when measuring, looking at open procedures in MIS or any other 500,000 procedures that are out there for bunion correction. We need something standardized that we look at preoperative and postoperative to see if the comparison between MIS and open or other procedures are valuable. So our study actually looks at specific parameters that you should be looking at pre-op and post-op in every single bunion surgery so that there is something that you can compare to. So the main thing that Dr. Sormin and Dr. Riddles have talked about, IMA and HPA and sesamoid position are the main ones, but we also have added some other parameters that we should be looking at. So IMA and HPA, DMA, angles angle, sesamoid position especially is something that needs to be looked at more with the pronation and frontal rotation. And then hindfoot alignment, we in SMASA is fortunate enough to have a weight-bearing CT to see how alignment actually works with bunion surgery. So that is something that we started doing. And then obviously crystal integrity. Next one. So these are the parameters, as you already talked about, that we look at in literature that talks about if these are not corrected intra-op, how much reoccurrence happens. As you can see, the HPA is less than 15 degrees or greater than 15 degrees. There's a chance of 14% overall recurrence. And if it's greater than 20%, there's a chance of 10%. And sesamoid position also, if it's between 5 or more, there's a chance of 10% recurrence chance. Next slide. And IMA, as we talked about, as Dr. Amin mentioned, there's a 1 out of 4 chance of reoccurrence if it's not corrected properly. DMA also, and ankylosing angle metatarsal adductus is something that needs to be corrected before the bunion surgery itself needs to be taken into consideration. And first metatarsal pronation is something new that we are taking into consideration of date and paper. Next. And hindfoot valgus is massive. We actually have a weight-bearing CT of a person we started doing before bunion surgery. And this has proven to be noteworthy that this needs to be also accounted for before we correct the bunion itself. So all these parameters that we're looking at gives us a baseline to compare apples to apples when comparing different MIS procedures or open procedures in bunion surgery. Next slide. And these are just to show that, hey, there's so many different ways to do the bunion surgery, and some procedures are good at fixing some aspects or parameters that we talked about. So it's also good to take into consideration what procedure needs to be done and selecting the right procedure to correct the right deformity so that when we are reading literature, we can see, hey, are we actually correcting the same thing all over? So these is the reason why Dr. Allen wanted me to do this research, because there's nothing post-op or pre-op right now that says, hey, these are the values that we should be looking. So if the bunion itself is not corrected in the first place, then we can't really compare the two papers. So that's, I think, into our research that we're doing right now. I can skip through next. And also next, and these are some other parameters and procedures and how these procedures were corrected. And last one. Yeah, some more procedures. And this will all be added into our research paper that we soon will be publishing. So yeah, that's it. Dr. Amin, do you want to take over?
Yeah, let's go to the next slide. Let's go to the slide. Next slide there. Next slide. Yep. So I wanted to talk just a little bit about the fellowship before we wrap up. So I'm the outgoing fellow. I got another 2 weeks here, and then AJ and I will overlap a little bit, but essentially AJ's taken over in August. So the focus of this fellowship is sports medicine and reconstructive surgery. And it's I believe it's the only sports medicine fellowship in Texas, and there are not a lot of them in the country overall. And this fellowship is with an orthopedic group. They have 2 foot and ankle specialists. One is an orthopedic surgeon who did a 1-year fellowship in foot and ankle surgery. That's Dr. Ogden. And then Dr. Allen is a fellowship director, and he's a podiatrist with the orthopedic group, and he's one of the founding partners of the group as well. And we see a lot of athletes in the area. They had for a long time, they were partnered with the Spurs basketball team. Some of the semi-professional soccer leagues in the area, they see those players, and almost all the high school football players, basketball players, and various other sports. So one of the great things about this fellowship is that you get to see a lot of pathology in pediatrics and young adult athletes. They're really healthy people. And that was different, a little bit different from my fellowship that I did, my residency that I did, where we were seeing more of a unhealthy population, a lot of diabetic population, lot of nails, wounds. So this was a nice change to see a different population than what I did in residency. Let's go to the next slide here. So the fellowship overall is 13 months. And the 13th month, that last month, you overlap with the new fellow. So you get to interact with the new fellow and you train them. So I spent a month when I came here with the last fellow, and I think that was really helpful. They kind of show you what to do, how everything works. And it's kind of like having an upper year. And it helps you transition into that fellowship for the first month. As I said, big part of the practice is sports from all the athletes we see. I would say it's probably about 70% sports pathology, but 30% general podiatry as well. We do get a decent bit of trauma that gets referred to the clinic, ankle fractures, pylon fractures, but not super complicated pylon fractures. But we have seen some more lately, calcaneal fractures and definitely Jones fractures. The orthopedic practice, they have about 9 clinics throughout San Antonio. We primarily go to about 3 of those. And also we have a surgery center in each of the buildings that the clinic is in. And then there's a Saturday sports clinic, which is about 9 months out of the year. And we see athletes from all over San Antonio, primarily high school athletes that come in during the football season, soccer season, whatever it may be. And we kind of treat some of their acute issues at that time. Next slide. So what are some of the common procedures that we do? I would say Achilles ruptures, along with insertional Achilles tendinopathy, such as Haglund's deformity. We do a lot of perineal repairs and lateral ankle stabilizations, and some ankle arthroscopy and osteochondral lesions. The trauma I talked about a little bit, definitely a lot of ankle fractures. We see a few pylon fractures. We get calcaneal fractures and a lot of Jones fractures. And as far as some more general podiatry and reconstruction, we do a lot of bunion surgery here, certainly a lot of lapidus, flat foot, cable varus correction, triple arthrodesis, and a decent amount of nerve releases as well. We've done a bunch of tarsal tunnel, common perineal nerve releases, which I didn't do a lot of in residency. Certainly done a number of those here as well. Next slide. So that's our overall presentation. If anyone has questions about the fellowship, feel free to contact me. It's just my first last name, suril.amin@gmail.com. And I'm happy to connect and talk to you further about the fellowship. And these were our references. Thank you, everyone.
All right, thank you all for joining us tonight, and our presenters did such a great job. For anyone who is not familiar, the critical appraisal sheets are available through the University of Oxford for free. They're sheets for each study design, and they provide us a step-by-step framework for assessing the internal validity, the reliability of the results, and external reliability and validity. Now, that was a great presentation, but I do have one main caution that popped up for me when I read the first article, which was that this was primarily based on postoperative exposition or recurrence, not risk factors, and they really did not define what recurrence was besides that. And so it doesn't tell us whether the patients that are recurrence in that group, they're not really telling us if the patients are symptomatic, they're dissatisfied, or if they have any functional limitation, and whether they're even considering revision surgery. And so I do find your future research very interesting because while we do need that radiographic definition, I think we also still need to better define recurrence in general in terms of real life and real patient populations. Um, I do have a question for Dr. Miller, our PICA representative here tonight. From a risk management standpoint, what should surgeons document when counseling a patient about choosing minimally invasive versus open bunion surgery, particularly regarding these recurrence and expectations that we should have?
Awesome. That's a fantastic question. I have a couple of points I want to go over that's all related to that. But first and foremost, I thought that was a fantastic Journal Club presentation. I thought it was excellent how you guys broke it down and went through it step by step and came up with your own conclusions outside of the conclusions that were presented in the journal articles themselves. And critical thinking is of the utmost importance when you're completing your residency and fellowship. And it's even more important afterwards when you're on your own. And the reason I bring up critical thinking is because, especially when you're on your own, you have to be proactive in these situations when patients are coming to you discussing surgical intervention about something that's affecting them. When you're more proactive instead of reactive, that's the biggest tip that I can give you on risk assessment. So, patients are coming in, they have a bunion deformity. You've tried conservative therapies first. Always try conservative therapies first. One of the things that I would caution is if you get a patient who comes in and demands surgery right away and they haven't tried anything else, that's a big red flag. More often than not, that they either have some ulterior motive or are not fully educated on the pathology that they're experiencing. They may have even seen somebody else and weren't happy with the results or with the treatment options that were presented to them there. So I always caution anybody who comes in and wants surgery right away without even attempting any conservative therapies. That's one. But going into what Dr. Riddle was talking about before, you need to be comfortable with these procedures, right? This minimally invasive is the big, sexy thing that's out there now, and everybody's talking about minimally invasive. The advancement in technology is great, and the new hardware with the new techniques is fantastic. But for the younger listeners out there, is that minimally invasive was huge in the 70s and 80s and went away, came back in the 90s, went away, and now is coming back again. And the reason it's coming back again is because we have these advancements in these techniques. But you have to be comfortable in what you're going to do and how you're going to do it. If you are not comfortable with these minimally invasive techniques, or if it's something that you know what the procedure needs to be but haven't done, that's something that you may not want to do on that patient until they're comfortable, until you're comfortable. Now, what I always say is that if ever I have a patient who comes to me to talk about minimally invasive, and now, AI, Claude, all this stuff, you go ahead and you put this in there, patients are coming with packets of information ready to go. They feel like that they know more than you do because they've done their research. And I'm sure you guys will have heard that or will hear about it, that these patients have done their research, right? So, what I always tell my residents and any fellows that I work with and young practitioners is that if you think a procedure is appropriate, would you be comfortable having someone with your skill set doing that procedure on you? If you're not, if your answer is automatically no, then that's something that you need to tell the patient on. One of the things that's tricky about risk assessment with surgery is that patients will ask you, how many have you done with these? How many have you done these? And there's a thought process on to kind of skirt around their answer. And there's a thought process about being truthful. And there have been cases that I have been asked to review and look into where the person who underwent the surgery, there was a complication, and as they get more in depth, they find out that the surgeon performing it maybe had only performed one or two of these before. And the biggest line or the biggest regret from these patients is, well, if I would have known the surgeon hadn't done this a significant amount of times, I never would have had the procedure. So when you're assessing patients for surgery and discussing risks, honesty becomes the best policy. And in a world where we're pressurized, number one, to perform greatly, to do a lot of things, and for certification purposes, sometimes it's tough to say no to a surgical case, right? Especially if you need it for hospital privileges or insurance credentialing. But at the end of the day, you're going to need to rest your head on that pillow comfortably and knowing that you did the best that you could and you've given appropriate care. And that's the first step in being proactive in risk management is if you can be comfortable in the care that you're given. So the more you can look ahead about the potential complications that this patient can experience, the potential risks and the potential benefits, and have that discussion with these patients, the less likely negative outcome slash litigation can happen. Anytime I have patients coming in talking about any type of surgery, I'm always discussing anything and everything under the sun. I have a list that I have come up with that I have talked to a bunch of people about, and I give the patient a list of all the risks. And it's almost like those commercials of when you're a new medication and then they say potential side effects of hemorrhage, diarrhea, all this stuff. And you're like, well, why would I take that medication? When I give these risks to these patients, they say, well, why would I have this surgery? And you have to refer to that and say, there are potential of these risks, but there are possibility. And when the patient knows about these ahead of time and that there is a possibility of something were to happen, if it does happen, they're not smacked in the face with it. They knew about what could possibly happen. That proactiveness is what will save you in the future there. And I'm sorry for going on a little tangent there, but I want to try to impart as much knowledge on you guys as possible because I know we'll have Dr. Amin being a new attending out there. So it's as much as you can absorb now from your fellowship and as much as you can absorb from your colleagues around you, the better off you're going to be.
Great. Thank you so much for that. I'm in my first year out, and I can tell you I did a fellowship, and it's still scary at times, but having these conversations ahead of time with patients really changes the dynamic that you have with the patient and the trust in general. It really does help.
Absolutely. And then
Right.
just one thing
We,
time with
yes,
the
please.
patient. If you can add and make sure that you allot enough time to these preoperative appointments and these postoperative appointments, these are not 5-minute appointments. They are not in and out. You take as much time as you need and you schedule that accordingly. Don't be pressurized to book 7 patients in an hour where 2 of them are pre-op in that hour and you're all of a sudden 2 hours behind because they needed more time. Make sure you book appropriately.
Definitely would agree with that. All right. For the fellows and future fellows, given what you have talked to us about today, when you're talking to patients after a procedure that you've done for bunion repair, and you see the radiographic findings that could indicate some level of recurrence, at what stage do you think you would start talking to patients about potential recurrence if they're not demonstrating any symptoms of recurrence besides the radiographic findings?
I don't have as near much experience as the other panelists per se, but in my brief experience, I'm a third year resident, but I've seen a lot of patients, quite a few that had a bunion recurrence, and some without symptoms and some with symptoms. And I think that's a big thing to note too, that if the patient's happy and you even on radiographs, you see that the bunion is starting to recur or is recurring, I might mention that to them. But also, if they're not having any symptoms, I would say probably nothing to do until there is. But I don't know if anybody else agrees with that or not. But
I
Um,
could say what we've done here, and luckily we haven't seen too many of these, but when we notice something, we generally mention it to the patient early on. And then we will typically document that in the note as well, just so it starts that conversation, or at least puts it in their mind that, hey, we noticed this on the X-ray. This may not be an issue long term. We'll have to wait and see. And a lot of times, even though something may be a little off, it doesn't present a problem long term. But the patients generally appreciate the honesty, and they're very receptive to the feedback.
Yeah, I mean, I definitely agree with Dr. Amin and Dr. Riddle. Like, I finished residency and I see a lot of complication from bunion. And the patient expectation, I think, is that's the key. Like sometimes clinically, this patient definitely need Lapidus because of hypermobility and the big IM angle. But sometimes less is better. Some patients said like, I want to walk right away. Like I want to walk with the surgical shoes right away. I mean, you might just do a calish. It might not be perfect procedure for the patient, but it's a perfect procedure. It's perfect procedure for that patient's situation. So, and also like as Dr. Riedel talked about, if there's no pain, I mean, it's better just to leave it, you know. Um, that's my opinion.
Yeah, that's great. I would agree with all of you. Less is more for some patients, definitely, and transparency is key. I go into my pre-op appointments and I go through all of the risks. It's not going to be perfect potentially, especially if we do choose procedures that are the lesser option as opposed to potentially doing a Lapidus or full fusion. And so the patients are really receptive to that. And then afterwards, if I see any signs, I also do go through radiographs with them in the appointments. I have my iPad with the x-rays, and I'm pretty transparent with them. And most patients are really happy with those outcomes and those results and just how we create that communication and relationship with them. But of course, Dr. Amin, you also touched on the important point is that we need to always document that. Especially in today's day and age, we need to have some level of defensive documentation as well. So if we have any questions, please send them in. Any of us would be very happy to answer them, or if any of the panelists have any other input. Right. Okay. If nobody has any more questions or comments, we can go ahead and close out for tonight. Thank you all for joining us, and thank you to our presenters for such an excellent discussion, and to Dr. Miller and Pica, of course, for their support and insight, and really just to everyone who joined us this evening. Hopefully we'll see you again next month.
Thank you.
Thank you so much, doctors.
Thank you.
Thank you.
Thank you, Dr. Miller.
My pleasure, guys.